Can you hear now? Yeah? Okay. I don't know what happened. Thank you everyone so much for joining the AYA session this morning. And we have a really nice panel of speakers for you today. I'm Becky Johnson, the chair of the AYA committee. My former co-chair, Mark Lewis, has stepped down and is going to remain active in SWOG and in AYA initiatives. So hopefully he's on the call, and we'll look forward to hearing from him in the future as well. Next slide, please. We're pleased today to welcome a new patient advocate, Allison Rosen, and also a new vice chair of the AYA committee, Dr. Lucia Nappi. The speakers today are going to reinforce the theme that we've heard in many AYA sessions, which is the necessity and the value of multidisciplinary collaboration in AYA projects of all sorts. And so our first speaker is going to be Allison Rosen, who's going to tell us about her own personal journey from a cancer researcher through her own lived experience as an AYA colorectal cancer patient, and now as a nationally recognized advocate who's going to be a real asset to our committee. Next, we're going to hear about the research interests of our new vice chair, Lucia Nappi, who's spoken to this committee before. And she's going to tell us about the blend of basic science and clinical research in the development of miRNA 371 as a marker for testis cancer that will hopefully someday replace the need for radiation and CT scans for surveillance after a testicular cancer diagnosis. Next, we're going to have Andrea Hartstark from Kaiser Permanente in Northern California, who's going to tell an interesting story about telehealth in AYA cancer care and how a novel use of an EPIC tool has allowed clinical researchers to look at large populations of patients with testicular cancer and really consolidate their management, allowing them to be cared for by patients or by providers who do lots of testis cancer management, improving outcomes. And then Susan Parsons is going to talk about patient-reported outcomes in S1826. Susan is a COG member, and she can comment on the really outstanding collaboration between COG and SWOG in the development of this trial. And then we'll have some time for questions and discussion. So first, next slide. I'd like to introduce Allison Rosen. Again, she was diagnosed with colon cancer at the age of 31. At the time was working as a researcher, and now is a patient advocate working out of MD Anderson, and she's going to tell you her story. Welcome, Allison.
Okay, thank you so much. Sorry, I couldn't figure out how to, can't even turn my screen on, but you can see my pictures here. So a brief overview of me. I didn't want to put a bunch of words on a PowerPoint, so I wanted to show pictures because I really believe actions speak louder than words, which I know most of you will agree with. So like we said, my name is Allison Rosen. I was diagnosed with colorectal cancer at the age of 32 while I was working in a cancer research lab. So I worked in that, it was a blood cancer research lab for about 12 years. And in that time period, about 5 years of that was spent in active treatment for colorectal cancer. During that time, you can see many different pictures. I started becoming involved in advocacy heavily and really heavily involved over at MD Anderson where I was treated. I'm a part of a young adult advisory council over there. I'm a part of a patient family advisory council over there. I've gone to Capitol Hill a few times to advocate about policy. And I slowly moved into cancer prevention research. after I was told I had no evidence of disease and I was cancer-free. So my career totally shifted after my cancer diagnosis into something where I could use my story, my voice, and my experience in a lab to help sort of bridge that gap between the patient and researcher. You can show the next slide. And so that brings me here to SWOG. I learned about SWOG when I was at the National Coalition for Cancer Survivorship Conference a few years ago. They told me about it, and I applied, and I was just until recently the community AYA advocate. And when the research AYA advocate position opened, I applied because I obviously love research. I had worked in research, like I said, for a long period of time. Cancer prevention is still research. It's just a different form of it. And you can see me at GI ASCO, some symposiums through work. I've gotten some awards, but again, I really want to use my story, my voice, and my experience outside of work and inside of work to help this committee, you know, like bridge that gap between researcher and patient, because I've been both. And that's a little bit about me. Like I said, if you want more information, I'm happy to provide it, but pictures sort of show how active I am. So I really want to help in any way I possibly can, through the patient perspective, but also as a former researcher.
Thank you so much, Allison. And I am personally just delighted to have you as a member of this committee. I really think that research is showing, and SWOG is a shining example of the fact that close involvement of advocates in every aspect of the design and implementation of research trials is so important. And so we are very pleased to have you on this committee and hear your voice and help you or have you help us you know, design our way forward on this committee as well. So thank you, Allison. And next slide, please. And next, Lucia, Dr. Nappi is going to tell us about miRNA 371 in testis cancer. And again, Lucia, I'm so happy to have you working on this committee as well as the vice chair. And I think that we are going to have a strong foot going forward. Testis cancer has been kind of a flagship effort for the AYA committee, with this S1823 trial being really one that has been spearheaded by the AYA committee. So I'm happy to introduce Lucia and hear the updates that you have.
Thank you, Rebecca. Thanks for the invitation and thanks for the opportunity to join to the AYA committee. So today I'm gonna give you some updates about S1823, which is the prospective observational cohort study in patients with early stage germ cell tumor of the testicle. And Dr. Nichols and myself are the co-chair for this important study. So I'll give you a little bit of background, and I'm very happy that Alison is here because obviously she can, as a patient advocate, but also as a previous scientist. So can you go back to the slides? Probably help us to translate these kind of scientific findings and background to the patients as well. So microRNA 371 is a small RNAs. RNAs are secreted in the blood, and it's expressed in more than 90% of patients with germ cell tumors, and in both seminoma and non-seminoma, which is important because especially for seminoma, we don't have reliable tumor markers most of the time. And the beauty of this biomarker is that it's extremely specific for viable germ cell tumor. And in fact, the only other condition where we can detect this microRNA in the blood is pregnancy, which doesn't really apply to our patient's population represented by male. It's not expressed by teratoma, but by all the other subhistology group of non-seminoma, and it's expressed by seminoma, as I mentioned. And the levels of these microRNA are strictly correlated with the clinical stage. So the more tumor the patient has, the higher is the expression of these microRNA in the circulating blood. And the rapidly decrease and disappear after a radical and successful treatment. So it's either after surgery or after chemotherapy, for example. So these heat maps here shows very clearly that non-seminoma and seminoma testicular cancer tissue overexpress two clusters of microRNAs, very similar to each other, while in blue, teratoma and healthy tissue do not express very low levels of these microRNA. And these happen in both pediatric germ cell tumors and adult germ cell tumors. Next slide, please. So there are a lot of characteristics of this biomarker that summarize the ideal biomarker characteristics. As I mentioned, it's related strictly to the tumor burden, to the stage, and rapidly decrease after treatment. These microRNAs are extremely stable in the peripheral blood, more stable than circulating tumor DNA, just because they are protected by proteases degradation, because they are secreted in protein microRNAs complexes. And next, please. We need only a very small amount of plasma. In my lab, we use 200 microliters of plasma to extract these microRNAs, so they are extremely abundant in the peripheral blood. Next. The method we use, it's a simple real-time PCR, which is useful to quantify the expression of these microRNAs, but also, as I will show you, for a qualitative analysis. Next, please. The extraction kit is commercially available. And next. The cost is estimated about $60 per sample. So it's overall very reasonable and contained. Next slide, please. So we did publish this paper in JCO at the end of 2019, where we essentially demonstrated that this microRNA 371 is very accurate in predicting the presence of active germ cell tumor, both seminoma and non-seminoma, across the spectrum of germ cell tumor malignancy. So we did observe and analyze the microRNA 371 in patients with early stage disease during surveillance, but also in patients with more advanced disease prior to and post chemotherapy. And the area under the curve for microRNA 371, this patient's population was 0.97, which was much higher than our current golden standard, which are CT scan and classic tumor markers by HCG, LDH, and alpha-fetoprotein. We didn't have any false positive over 132 samples analyzed, so our specificity and positive predictive value were 100%, and only 2 false negative, and therefore the sensitivity was 96%, and the negative predictive value for active germ cell malignancies was 98%. Next, please. So, in order to be using currently this biomarker in our clinical practice, we still need to validate this microRNA clinical utility. Next. And in order to do that, we have to design large and prospective clinical trial. So S1823 will answer to a simple question, which is, can we use this microRNA 371 to detect tumor relapse in patients with early stage active germ cell tumor? Next. This is the design of the study. So patients with early stage testicular germ cell tumor, stage 1, stage 2A on surveillance, but also more advanced disease, so higher risk, patients with metastatic disease. Next. will be eligible for this study. The patients with low risk and moderate risk will be required to provide blood samples every 6 months or every 3 months during their active surveillance schedule. Next, while the patients with high risk will provide blood for microRNA 371 test prior to starting on any active treatment. So it can be radiation, chemotherapy, or surgery, and then post the treatment and post-surgery eventually. Next. The study is very easy. It's very low demanding in terms of time and commitment to the patients and the investigators. We only ask additional strike tubes to be collected at each time during the surveillance and at the time of relapse. For patients who are not going to relapse, essentially, we just follow those patients according to their own schedule of surveillance for 3 years. And then the samples will be stored at nationwide, which is the SWOG repository, and I will be receiving an allocoat of the plasma for all the patients in Vancouver, where we'll do the analysis for microRNA. So there will be no real-time results available for this study, but we will start the analysis once we have enough events, so enough relapse. Next slide, please. The primary endpoint is to establish the positive predictive value of microRNA 371 detection relapse of the disease, but also, and I think this is even more important, to see by how much time, if at all, microRNA 371 expression becomes detectable before, hopefully, the tumor becomes clinically detectable. There are a lot of secondary endpoints deriving from SWOG-23. I think one of the most important is that we are going to establish the biggest clinical annotated biobank for patients with testicular cancer that will be used for future translational studies. We are also banking DNA, for example, and also will get samples for explore and investigate and hopefully develop new biomarkers for teratoma patients. Next. Patients with testicular cancer at any stage, new diagnosed testicular cancer at any stage, are eligible for this trial. And obviously, the statistical power and analysis will be based on patients with stage 1, stage 2A, but also, as I mentioned, patients with more advanced disease can be enrolled. Next. There are a lot of correlative questions that will be answered by this study. One of the most important is the pattern of care in patients with testicular cancer and modern real-world care testicular cancer a management strategy. And then we have a lot of room for quality of care, economics, comparative effectiveness analysis as well. Next, please. In terms of statistics, we aim to enroll almost 1,000 patients, including low, moderate, and high risk. But as I mentioned, the analysis will be done on the patients with early stage disease. We target 50 relapse in patients with seminoma and 100 relapse in patients with non-seminoma. And we plan to do the interim analysis 40 relapse in seminoma and 50 relapse in non-seminoma. Next, please. Next slide. So the study has been centrally activated in the US at the end of July 2020 and in Canada in December 2020 through the CCTG, the Clinical Cancer Trial Group, Canadian Clinical Trials Cancer Group. And as on April 12, 2021, we have enrolled 132 patients, and those are the patients with low, moderate, and high risk. So the trial is enrolling very quickly, and thank you very much for the collaboration and your effort in this trial. Next. As I mentioned, also in Canada, we have that open, and the first Canadian patient was enrolled in December in Victoria. Next. In terms of funds, we have the support of the Hope Foundation STAR grant for the analysis of relapse samples, but we did apply for also for an R01 diagnostic and biomarker integrated grant, and we had a very good score. So although the funds decision have not been released yet, and we have to wait until August, there are very good chance that we may get this grant, which will cover the cost for the serial samples analysis. And there are other specific germ cell tumor funding opportunities we are also exploring, including the DoD grant. So there is a DoD grant application specifically for germ cell tumors. Next, please. I think this is my last slide, and thank you very much for your attention.
Thank you so much, Dr. Nappi. We have a couple of minutes for questions. So congratulations on the outstanding score of your R01 and of the rapid early accrual since the study was approved. Have there been any surprises in the accrual? First question. And second question, I wondered about, you mentioned that the SWOG study, germ cell tumor study that's currently going on is accruing rapidly also. And I was wondering if there are plans for collaboration or pooling the data for miRNA 371 between those two data sets.
Yeah, so I think, yeah, the accrual is going very well. There have been some questions like across the common questions across the study centers. So we are working on an amendment on the protocol just to make it easier and try to address the most common concerns. It's very easy. So even with COVID, I think there was a huge uptaking of the study. So COVID obviously has delayed a little bit things, but not majorly, I would say. And for the second question, yeah, the SWOG study is not only about biomarkers. There is an optional arm where patients with testicular cancer on surveillance, pediatric and adult patients, are asked to optionally agree to donate blood for these correlative studies. Obviously, we are not, there is no overlap between the study and the pediatric ward because our study is not recruiting patients in the pediatric age. And also seminoma is not usually a tumor of pediatric populations, there is no overlapping. And yes, absolutely, for future, there could be a collaboration, for example, for if we need for validation of our data between the two studies. I think that that is something that will be discussed absolutely in the future.
Excellent. Thank you so much. So we'll move on now to Dr. Harstark, and she will talk about telehealth in AYA cancer with a focus on testicular cancer. And if people have questions, if they want to write them in the chat as we go along, we can discuss them at the end of the talks, or else you can speak at the end of the sessions as well. Dr. Harstark.
Good morning. At least it's still morning where I am for a little bit longer. My name is Andrea Harstark, and I'm a medical oncologist at Kaiser Permanente in Northern California. I'd like to thank the committee for the opportunity to speak with you today. I'm going to share with you a little bit about the story of the development of our testis cancer program for Kaiser in Northern California. When I came to Kaiser Oakland by way of UCSF 6 years ago, there was a real gap in how we cared for these patients. Subspecialization at Kaiser, like many places in the community, was really in its infancy. At Kaiser in Northern California, we care for 4.5 million patients across 21 different medical centers. So we see about 150 new cases of testicular cancer per year. We have 100 medical oncologists and 100 urologists. So the average oncologist saw 1 or 2 cases per year. For a young, curable patient population, this is clearly not the ideal way to care for them. Next slide, please. So Joe Presti from Urologic Oncology and I set out to intervene earlier in the care of these patients by reviewing cases centrally. Our goals were to catch the cases early, to provide input for guidance, and then ultimately to consolidate the care to a smaller number of focused medical oncologists and urologists. Then we wanted to learn how to improve our processes along the way and figure out how to track these patients so that these young patients who believe they're invincible don't get lost during their surveillance. Next slide, please. So that is how our testicular cancer review panel was born. Our division of research helped us by creating an early ascertainment algorithm. This sends us an automated list once every 2 weeks of all new testicular cancer diagnoses in our system. So a patient makes it onto this list by having a diagnosis of testicular cancer added to their problem list in EPIC, a diagnosis of germ cell tumor in our pathology database called COPATH, or having an HCG and AFP checked in any single individual patient. That list then gets sent to us, and once every 2 weeks, the panel meets. Joe Presti and I, at least for now, run it each time for both consistency and efficiency purposes. Then there is a group of other medical oncologists and surgical oncologists who rotate through. There are about a dozen medical oncologists distributed geographically across Northern California and half a dozen surgical oncologists. So the two of us will participate each time, and then we'll have a rotating medical oncologist and surgical oncologist who rotate through, and 4 of us will meet every 2 weeks. This helps promote consistency, but also, just practically speaking, keeps it from being too big an ask of local departments in terms of excusing their physicians from regular clinic time. So we review all the relevant details of the case and review the scans ourselves. Our review is then recorded during this working meeting in a clinical note. In that note, we clearly write out the stage and have standardized recommendations, I'll show you in a second, that we have dot phrases for so that we can quickly provide recommendations and then modify them as needed for the particular details of the case. The note also provides resources on whom to approach for questions and flags potential patients for trials. We've actually put 15 patients on S1823 in Kaiser Northern California. We didn't have a coordinator in the beginning, but we have one now. Once we were able to demonstrate an improvement in outcomes, we were able to argue for a little bit of resources. So now that person can help us follow up on results we're concerned about and help us track outcomes of our patients. We also review any referred cases for inputs, so suspected relapses or cases where the physician isn't sure what to do, how to interpret a PET scan post-treatment of seminoma, and to re-review intermediate and high-risk patients after they complete their initial treatment. Next slide, please. So this is what a piece of our note looks like. In this case, for example, you'll see in that horizontal red box that radiology had actually called a para-aortic lymph node. This patient was called by the initial physician as being a stage 2A patient that with what was called was about 1.7 centimeters, which would have meant additional therapy for this patient. On our review, we thought it was collapsed small bowel and recommended no further treatment. We have 5 body radiologists who have agreed to be our referee radiologists and to re-review cases for us when we have concerns. We'd love to have a radiologist all the time, but this is how we stay lean and maximize our resources in the real world. In this case, the radiologist agreed with us and then went back to the original radiologist for us to modify their report. Next slide, please. In our note, you can also see in that first red box there that we then outline who the physician caring for the patient should go to if they have questions, both a medical oncologist and a surgical oncologist. The surgeon outline will later be the surgeon if an RPLND is needed, and they're copied on the original note so that they're aware of what's happening with the patient from the beginning. We provide a treatment recommendation with a brief explanation and then the subsequent surveillance guidelines. Next slide, please. So we've been doing this for almost 5 years now. In the first year, we looked at how the management had changed in really easily measurable ways. I think there are a lot of more subtle ways that management has changed, and I'll show you a couple of those. But just in terms of radiology and pathology alone, in that first year, the recommendations changed for almost 9% of patients just on radiology review. When we had reviewed, we found significant lymphadenopathy in 7 patients that had not been called on initial radiology review. We also found things that had been called lymphadenopathy that we thought should be observed or were not lymph nodes at all in 4 patients. And then we found something else interesting, which was that we found a lot of embryonal predominant stage 1A non-seminomas. In clinical practice, about 85% of these patients should have lymphovascular invasion, but we weren't seeing that called very often. So every time we saw one of those, we asked for GU pathology to re-review it. And it turned out that over half of the time, they observed lymphovascular invasion that had been missed when a general pathologist looked at it. So that increased the patient's stage from T1 to T2 and changes their risk of relapse, changes their risk-benefit discussion for treatment. It also changes our staging and outcomes data for Kaiser as a whole, and would not have been an observation we would have made if we had not been reviewing this large number of cases together. It took us a little while to figure out that this was something we needed to do. Next slide, please. As a result, we were able to go to pathology and make an argument that all non-seminomas needed to be read by GU pathology only. This was really key, just working in a practical system in the community. We really don't want to create extra work for people and duplicate work. And so the key was that now these cases were going to be read by GU pathology only from the beginning, so that this was not extra work for pathology. Not every case was being re-reviewed. And this took some work because they have to be routed around across Northern California to the 5 subspecialized GU pathologists in our system. We also learned that we needed to request that post-chemo films for intermediate and poor risk patients come back to our panel so that we could continue to be involved in these difficult cases. We sort of had to insert ourselves into the picture, and we learned that that was a useful thing to do. And then I think the coolest part of the process for us was that we saw empirically that things were changing, that we would see in the notes as the local providers were taking care of their patients, that they were telling them that this review was happening and that they wanted to confirm with us before finalizing the treatment plan. And that really happened empirically. You know, the management of testicular cancer is really so niche that I think a lot of people are very uncomfortable caring for these patients. And as we have subspecialized more, the care of these patients has gone more and more to the physicians who participate in the panel, but at some of the more remote medical centers, that isn't always feasible or practical or what the patient wants. So this model has now expanded to other uncommon cancers at Kaiser. The pathway for multiple myeloma, for example, sort of proceeded along a similar timeline to what we're doing. Melanoma is cared for the same way. Hodgkin's is cared for the same way. We have been asked to try and expand this work across Kaiser nationally, which cares for about 12.5 million patients. So work is ongoing to try and sort that out as well. Next slide, please. This has allowed us to really improve the standardization of our care and has allowed us to consolidate the care, both of which we know are really important components of the management. So on the left here, you can see that we have been able to improve the number of stage 1 seminoma patients who are put on an observation plan rather than an adjuvant therapy plan. So observation is really preferred in this setting. So we've been able to increase that from below 50% to 88% as of 2018. So that's something we're very proud of. On the right-hand side, you can see these are the number of RPLNDs that are being done by our high-volume urologists, our surgical oncologists. And so you can see that that really has improved pretty dramatically. We have 4 fellowship-trained surgical oncologists in our system who are doing all the post-chemo RPLNDs, and that is not how it was back in 2015. So I feel really confident that patients are getting a higher level of care. Next slide, please. And then the question came of how to appropriately track these patients, how to make sure that they don't get lost after their treatment is completed. So our IT department worked very hard on creating a Workbench reporting tool so that there are some components of the patient's information that we have to manually input, including the stage and the histopathologic subtype, the end of treatment date, but that the system can then pull the rest of the information. It can pull the surgical date, it can pull the what chemotherapy or radiation or additional surgery has been received, and then figure out what surveillance the patient should be undergoing according to NCCN guidelines, which we had surveyed our medical oncologists and urologists, and that was the system they felt most comfortable with. And then the system can tell us, using those little colored balls, which I learned are called Harvey balls, that tell us when things are due or overdue, so that if they have a green light, you know that everything is up to date. If they have a yellow light, it's a little out of date. And if they have a red light, it's significantly out of date. Next slide, please. During our treatment conference, we enter the stage and histologic subtype. The end of treatment date has to be entered by the physician caring for the patient, and then that all determines the follow-up algorithm. Now, this can then be followed up by staff who are capable of ordering all the different surveillance and letting the patients know that it needs to be done. All of their outreach is digital, primarily with secure messaging. So it's been really helpful, particularly during the pandemic, to function that way. I think the main challenges to this sort of program, certainly having the technology function appropriately, it is a challenge within the system. It's complicated for the system to figure out exactly what treatment and where it's been delivered, and having the adequate support and funding for that. And then during the COVID pandemic, we've actually lost the funding for our staff to monitor it. So I'm hoping at some point that that will come back, but that has created significant challenges within our system. Next slide, please. So where do we go next? We would really like to work on improving the surveillance. I've alluded to here some of the challenges with that, and improving what we do for these patients with survivorship, including things like metabolic monitoring for patients who've received cisplatin, things like that. We'd like to be able to continue to expand our case review, hopefully across Kaiser nationally, and continue to improve that as we do it. We'd like to work on further consolidating care. Right now, we're working on limiting the thoracic surgeries in these post-chemo patients to a small number of thoracic surgeons, and improving the communication there. We'd like to be able to more effectively mine our data. There are certain challenges at Kaiser across sharing data elsewhere, and I think we're a large volume center. We'd certainly like to be able to connect with others to make that data more powerful. And then I think we'd like to continue to enroll to clinical trials. I'm proud of the fact that we've been a very high enroller to S1823. I think that we are very well set up to do that. And I think there will be lots of future opportunities there as well. Thank you very much.
Fantastic. Thank you so much. If you have questions, please put them in the chat. Kaiser Permanente, of course, is kind of a world leader in rapid process improvement. And I was interested to hear that the pandemic has affected even your funding and staffing for these projects. And I wondered if you could just briefly tell us what kind of effort was involved in putting together and sustaining this team in terms of FTEs, and in what sounds like you have a research coordinator or something who is managing all of these patients in various locations, and how much of a person's time does that take?
Yeah, that's a great question. So we actually kind of fought tooth and nail, quite honestly, for about 20% of a coordinator's time. And we happen to be very lucky that, this is a college educated but not particularly medically educated person who's way too qualified for the job she's doing, which is what really makes it possible. But that it takes a full kind of 20% of her time to track down all this. And honestly, you know, when you're not in a big academic center with the research funding and the time set aside, you have to have a local chief who actually believes in the mission of what you're doing and is willing to set aside some of your time to do this. And that's just a really practical concern. And I happen to be based in a urology department instead of a medical oncology department. And so the urologist I work with, we sit side by side, and our chief lets us take the time to do this. So about 5% of my personal time is donated to this effort. In terms of the actual tracking of patients, there is a survivorship program at Kaiser that had 3 full-time nurses who did survivorship for many programs, not just ours, including colon cancer. And during COVID, what would happen was if somebody would leave to go find another job, they were not allowed to be replaced. And so the program really dwindled under that sort of increased pressure. But it was essentially 3 full-time nurses to care for, you know, testicular cancer, colon cancer, and a couple of other small cancers in terms of surveillance and tracking them.
Interesting. Thank you. So essentially, once you get the system built, it's a manageable amount of FTE if you can keep the people employed and not have to replace them.
Yes.
Yeah. Okay. Thank you so much.
Thank you.
And next, we'll hear from Dr. Susan Parsons about PRO and Hodgkin lymphoma. Susan.
Can you all hear me?
Now we can.
We can hear you.
Great. I'll repeat that I just want to thank Becky for the opportunity to present on this study. And I really do think it's the poster child of collaboration across the NCTN. Under the SWOG leadership, we all have come together and activated this study about 21 months ago. If you go to the next slide, please. This is our accrual, and I prepared this slide a couple of weeks ago, and it's grossly out of date now. We had 51 patients put on study over the past month and are now up to 414 patients. And as you can see from the pie chart, this cuts across all of the different NCTN groups, with about 36% of the patients coming from the children's oncology group. Next slide. Briefly, the schema of the study is that this is a phase 3 study for patients with newly diagnosed advanced stage Hodgkin lymphoma. Patients were 12 years of age and older. They were randomized 1-to-1 to 2 different novel therapies with a common chemotherapy backbone of AVD, adriamycin, vinblastine, and dacarbazine. So they either were assigned to nivolumab plus AVD, or brentuximab vedotin plus AVD. Nivolumab, as you know, is an immune checkpoint inhibitor, whereas brentuximab vedotin is an anti-CD30 directed monoclonal antibody with a chemotherapy moiety attached to it, which is highly toxic once it enters into the cell. Patients on both arms received 6 cycles of therapy, and then those patients that at the beginning of the study intend to use radiation, or the chemotherapy is followed by residual PET guided radiotherapy, and I'll tell you a little bit more about that in a second. Actually, if you click to the next, there are several criteria for the use of involved site radiotherapy at the end of treatment. All pediatric patients must declare intent to radiate at the end of the study, whereas the non-pediatric sites can use radiotherapy if these different criteria are met. If the PET scan shows a Doble 4 or 5 at end of treatment, if there is greater than a 30% reduction in the maximum transverse diameter, and there is residual activity in peripheral lymph nodes or other extranodal sites. Next slide. The primary aim of the study is to look at progression-free survival in across these two arms, as I mentioned. But the secondary outcomes include looking at event-free survival, which is something that we use more commonly in pediatrics, overall survival, and complete remission rates at the end of treatment. One of the interesting additional studies that were added to this trial were a patient-reported outcomes endpoint and a symptom endpoint, and I really want to focus on those two for the remainder of our discussion. The patient-reported outcomes were powered to compare patient-reported fatigue, peripheral neuropathy, and health-related quality of life across the two study arms. And we were particularly interested in looking at the endpoint of 12 months post-registration and 36 months post-registration for each of these endpoints. In fact, we were able, with the sample size that we have, of partitioning our alpha coefficient in quarters so that we were able to look at patient-reported fatigue at the 2 time points and patient-reported neuropathy at the 2 time points, which is a luxury that I have not, in my experience to date, been able to realize. So this is very exciting to me to be able to look at those longitudinal relationships of these two very important endpoints. We were also able to look at symptom burden and the patient-reported adverse events and compare those directly to the clinically graded adverse events at each treatment cycle and in planned follow-up. You can go to the next slide, please. Very, very briefly, this is newly diagnosed advanced stage Hodgkin lymphoma, patients 12 years and older. We relied on good performance scores. And again, this is an example of the collaboration where for the adults, we used one performance scale, and for the pediatric patients, we used another, the Lansky Play Performance Scale, which has obviously different criteria, but is roughly the same scaling when you compare the two measures. Patients could not have peripheral neuropathy of grade 2 or higher at the time of registration. And this was an interesting, again, collaborative point in that most pediatric age patients do not have peripheral neuropathy at baseline, grade 1 or grade 2. But it's possible in older patients that you can see that related to comorbid condition, namely diabetes. The other thing that we specifically stipulated is that patients could not have active autoimmune disease or conditions requiring corticosteroids because we were afraid that that would potentially interfere with the efficacy of the immune checkpoint inhibitor. Next slide, please. Because of the broad age range that we were able to include in this study of patients 12 to greater than 60, the enrollment was stratified by age. And you can see the three broad categories we picked of pediatric, 18 to 59, and then 60 and over. We also stratified on the International Prognostic Score, which importantly was validated for use in adults, has not been validated in pediatrics, particularly since one of those prognostic criteria was age over 45. So there's a different maximum IPS score that could be achievable in a pediatric age patient. And as I said, there was a very different consensus-based approach to radiotherapy. Next slide. In terms of the patient-reported outcomes, we had made the decision to use the pediatric and the adult global health scale, which was developed as part of the PROMISE initiative. The PROMISE initiative, as many of you know, began in 2004 and was a trans-NIH initiative to really improve our measurement armamentarium for patient-reported outcomes. We relied on the PROMISE initiative also for the validated fatigue short form, and there are age-based versions of this measure, the 10-item version for pediatric and the 7-item for adult, but in research, those have been found to be equivalent from a measurement perspective. We use the FACT-GOG NTX as a measure of neuropathy, which we have successfully used in one of our other Hodgkin's trials in children 11 years of age and older. All of the measures were available in English, Spanish, and French to allow for participation across all of the different research sites in North America. With the help of Lynn Henry, and I will say that 5 times, we were able to identify 5 different assessment time points over the course of the trial for these 3 principal measures. We collect data at baseline, at the beginning of cycle 3, end of treatment, and again at 1 year and 3 years post-registration. With the help of Joe Unger and the rest of the statistical team, we have come up with very strict criteria about who stays in this study and who doesn't. And we have elected in the quality of life assessments to continue to complete the quality of life measures, even if the patient goes off protocol therapy for any reason. And again, we've keyed all of our assessments off of date of registration. Next slide. In terms of patient-reported symptoms, we relied on the patient-reported common toxicity criteria of adverse events, or the parallel measure called the pediatric pro-CTCAE. There was an important difference we discovered in these 2 assessments. One is that the pro-CTCAE, by virtue of its age, which is a relatively more established measure than the PD pro-CTCAE, is now available in English, Spanish, and French, whereas the pediatric measure is only available in English. As I mentioned to you, we had very specific criteria about when the patient-reported symptoms would be collected, which is summarized on this slide. And the very rich thing about this, from my perspective, is that we were able to collect this information with each treatment cycle so that we can really begin to describe when symptoms first appear, how long they last, and with what severity and interference. And we're then able to also collect them all the way through off treatment, and again, summarized at multiple time points. So we'll have a very, very rich trajectory with which to describe this. Next slide. When we selected the specific measures, we had 2 principles in mind. One is that we wanted to include symptoms that were relevant to both study arms because they use the same chemotherapy backbone. Examples of this include things like nausea, emesis, mouth sores, diarrhea, pain. And in the case of the adult battery, we were able to also include 5 free text fields where the patient could actually add additional symptoms that we may not have specifically queried. Hong Lee and I are currently looking at this to see if there's any theme to the free text which might suggest that we should add other additional symptoms for the last half of the study. We then added symptoms that were specific to each of the novel therapies. And these might include things like rash, pruritus, myalgias, arthralgia, shortness of breath that might be more commonly associated with nivolumab, as opposed to neuropathy, cough, or shortness of breath, or abdominal pain, more likely to be associated with brentuximab. We then worked with the architects of the pediatric pro-CTCAE to find commensurate measures in the pediatric library so that we would have strong alignment between the 2 measures across that broad age range I just mentioned. We also identified gaps in 3 different areas, between the two inventories. One is the pediatric inventory did not have a specific question about rash. Obviously, for developmental reasons, did not have a specific item on sexual health, and had not found it useful to ask children to add free text additional symptoms. Go to the next slide quickly, please. One of the important things about this is this information is really helping us understand the symptom trajectory with novel therapy. But it is not designed to be used to determine dose delays or dose modifications or any other protocol-driven activity or action, that we rely specifically on the clinician-graded CTC-AE for AE reporting and safety standard. But it will be very, very interesting to be able to compare head-to-head what the patients are telling us versus what the clinicians are telling us. And next slide, please. This is the collaboration slide that I think we should all be really proud of. There is representation across all the NCTN groups, helping to build the study, run the study. We have champions from each site. We have areas of expertise, including radiation oncology, radiology, obviously rich input from our medical and pediatric oncologists. I am the champion for the patient-reported outcomes. We're working with a stellar statistical team and a magnificent patient advocate, Hildy Dillon. Next slide. So I wanted to spend 1 minute, if Becky gives me 1 minute. I want to spend 1 minute to talk about how we took what we learned in 1826 and how we are now further advancing this across other AYA clinical trials. Mike Roth, who is the AYA discipline chair for the Children's Oncology Group, and I were lucky enough to receive a supplement to our U grant last fall, which allowed us to set up an AYA patient-reported outcomes initiative. Part of that initiative was to put together a task force to help us think about how we could systematically collect patient-reported outcomes across our AYA clinical trials, particularly if we can continue to do these collaborative cross-network studies. So this was an example of a consensus that we reached working with this PRO task force over the past several months, where we thought about what were the domains that would be of interest, how many measures might we, or questions we'd want to ask, how we might combine a profile of health-related quality of life with symptom-specific inventories. Again, how do we put together batteries that are both broad enough that they apply across diseases and across studies, but then also study specific enough so that each of the study teams can address a specific question. This has been an incredibly interesting and fun initiative. We've made a lot of progress in the past 8 months and look forward to continuing to work together to further refine patient-reported outcomes assessment in AYA trials, and hopefully can report back to you in the future on that. And with that, I'll stop. Thank you.
Thank you so much, Susan. That was fascinating and such a fine example of collaboration between COG and SWOG, not only in the treatment protocol for S1826, but also for the PROs. And certainly you and also Lynn Henry and Joe Unger in the stats group can be resources for other groups wanting to design PROs for their trials. But in the next 60 seconds, Susan, do you have any advice for people going forward in how to start such a collaboration and maintain it in terms of PRO development on future trials?
Well, I think the first thing that this showed me was that the collaboration of this nature is absolutely possible. I think that it also showed that there was strong alignment scientifically, even though there were specific logistical differences or different processes that each of the different cooperative groups was used to. We had to quickly come to the fact that we all believed in the study and that we really wanted to make it work. And we wanted to be able to bring novel therapy, especially to the AYA population, where we knew if we had followed our usual processes and our usual sort of siloed-based care, that we would not have been able to bring these agents to our AYA patients for probably 5 to 10 years, at which point they would have either been obsolete or, that the train would have passed. We would have missed our opportunity. I think the other thing is figuring out what's really, really important. And I think the radiation approach is an example of where we compromised on many, many things, but not on the use of radiotherapy. So that we wanted that to still be part of the pediatric-based treatment because it has really resulted in great success over the years. Whereas many of the adult trials have moved far away from the use of radiotherapy. So figuring out where the really important issues are and then stepping away from other issues that kind of are, we do this because we always do this, and I think it's sorting that out. And I think that under Jonathan, Alex's and other leadership, we were able to get to that point quite quickly.
Perfect. Thank you so much. And it's great to hear of all this progress. For those of you who need to go, thank you so much for attending this session, and hopefully we'll see you in person in the fall. There's one more question from the audience for those of you who have time. This is from Craig Nichols for Dr. Parsons. It says, where does DEI appear in PRO and in S1826? The meeting can stay open for a few more minutes for those who were able to stay.
Okay. Becky, could you repeat that, please?
Yeah, so where does diversity, equity, and inclusion and issues around that topic appear in S1826? And are there, I guess, any specifics in the PRO instruments to encourage diversity in the responses, is the question.
So that's actually one of the cornerstones of the supplement that we got. I mentioned one issue, which was the development of this PRO task force. The other thing that we did is we established a diversity and inclusion task force. And one of the things that we're specifically focusing on is improving the quality of our data capture so that we can, in ongoing studies and in future studies, have a more standardized way to really understand the patients we are serving and are not serving, so that task force is developing standardized assessments as well. And then the third thing that we're focusing on is improving data collection and data quality through electronic data capture. We're hoping, particularly among adolescents and young adults, as we move from paper and pencil to electronic data capture, we will get greater participation and retention in our studies so that we can look at the longitudinal recovery during and after treatment. And as Andrea said, also continue that into survivorship. So that's a very important point.
Great. Thank you so much for that. And with that, we'll close, and very much appreciate everyone's attendance, and we'll see you in the fall. Bye-bye.
Thank you. Bye.